Good morning, everybody. I would like to welcome you to the 8th Applied Genetics Workshop. I must say I was myself a bit amazed to think how many years this has been going on, and it's just getting stronger and stronger every year. I would like to introduce you then to the head of our Department of Pathology, Professor Erasmus. He's got so many good things that he has done over the years at this university. He's very interested in developing point-of-care diagnostic assays, and I'm sure that hopefully we will see some of those initiatives in your talk. Okay, but I'm sure in future we will see all those research coming out. So without further, I would like to introduce Professor Erasmus, and we're really looking forward to your talk.
Thank you. Good morning, everyone. Can you all hear me? Great. Thank you so much, Marita, for inviting me to this workshop. You know, when I took over the department early this year, one of my strategic intents for the Department of Pathology for the next 5 years is in fact to become leaders in what we call as P4 medicine. Some of you might know what is P4 medicine. Some of you might not know what is P4 medicine. But if you do not know what is P4 medicine, you better get ready, because that's where we are all heading. And indeed, I myself did not know what P4 medicine was until a year ago. But in some sense, we've been practicing P4 medicine all the time. It's just that somebody has brought that term together. And personalized medicine is very much part of what is called as P4 medicine. So we all know that today medicine is very reactive. It waits until a person is sick and then treats a disease with varying levels of success. And some of the medical aids, in particular Your Vitality, has been trying to put up a concept of wellness. You all know about it. That started about 5 years ago, and is pretty much in line with what we call as P4 medicine. But we know where we are going is that in future, by providing an understanding of disease at the molecular level, a systems medicine approach will eventually be able to predict when an organ will become diseased, or when a disturbance in a biological network could progress to disease. So that's where we are going. And in some instances, it's already happening now. In other words, diagnosis and the ability of a person to develop disease in the future is being determined right from birth. And this is happening because of the advances in technology that are rapidly taking place at a breathtaking pace. So if we look at drugs that we commonly use to treat patients, you will find that quite a few people who are taking antihypertensive drugs don't actually respond. The same happens with heart failure drugs. In other words, 15 to 20% of them don't respond. A similar situation with antidepressants, with cholesterol drugs, as well as asthma drugs. Now, these are some of the very common drugs that doctors use to treat patients with a variety of these fairly common conditions. So what is the message here? What is the fact here that is staring at us? The bare fact is that many of the patients that we are treating just don't respond to the drugs that we currently have. And more importantly, what we see, and this is from data from hospitals in the United States, that nearly 7% of patients in hospitals experience serious drug reactions. So even these drugs that we are taking have serious adverse reactions that can sometimes result in death. So, as I was saying, therefore, there is a new paradigm shift that is taking place globally. So what is happening is that we are moving from being reactive to being a more efficient medical, we are trying to provide a more efficient system of medical care, in which, if you look at the right, in which what you want to do, you want to screen for the presence or absence of disease, and then you need to make a right diagnosis, and very importantly, give the right drug. And through that, also monitor. So we're actually moving to that, because what has happened, or what is currently happening, is that many drugs that are being given are not the right drug, because many people have genetic differences with respect to polymorphisms in certain genes that metabolize these drugs. So medicine is moving very rapidly to ensure that you are able to identify patients who should receive a drug or who should not be receiving a drug, and look for alternate forms of treatment. Now, obviously, for you to do that, you must have the tools to be able to identify those patients. So therefore, what is P4 medicine? P4 medicine is a term that was coined by the biologist Leroy Hood in 2007, and is an acronym for predictive, preventive, personalized, and participatory medicine. And in fact, what it is trying to do is to plan to radically improve the quality of human life via biotechnology. So the emphasis is on biotechnology. So what's happening, the changes that are affecting us are being, in a sense, going through in a sense, happening because of the rapid advances in biotechnology. In fact, what is happening now is that biotechnology is actually moving ahead of some of the changes that we need to make. So the premise of P4 medicine is that over the next 20 years, medical practice will be revolutionized by biotechnology, as I said, to manage a person's health instead of managing a patient's disease. So we will not be waiting for disease to happen. We will be trying to make sure that we have a healthy individual, the whole concept of wellness. And that wellness will be defined through different, in different ways. So in this kind of medicine, physicians will be able to detect early warnings of disease so that they can take early action, such as adjusting their lifestyles to prevent disease. One example of that is the change in cancer treatments. You know that in the last 5 years, this has undergone quite a significant change. Emphasis is now placed, as you know, on early detection, followed by genotyping of the patient, which then determines which is the most adequate treatment according to the genetic background. And it's very likely, and that's beginning to happen. In fact, we are already doing some studies in which cardiovascular diseases and perhaps even neurodegenerative disorders will be the next targets for P4 medicines. So as we get more and more information regarding your genetic profile, we will be able, by and large, to predict whether you will be at cardiovascular risk, say for example, in 10 years or 20 years. So, and that risk will pretty much be predicted at birth. So, it's very clear. There are several benefits. It will detect disease at an earlier age. when in fact it is easier and less expensive to treat. It will, more importantly, stratify patients into groups that will enable physicians to optimize their therapy. It will also reduce adverse drug reactions. You saw how high they were, almost 7%. It will also improve the selection of new biochemical targets for drug discovery. So because of these advances in biotechnology that we are currently experiencing, what is happening is newer and newer new biochemical targets are being identified. And once you can identify the targets, you can then try to develop new drugs that will target these biochemical targets. So what is happening, or what will happen, and in some instances it's already happening, is that there is a shift in the emphasis in medicine, as I said in my opening slide, from reaction to prevention, and from disease to wellness. Now, it's important for us to realize that P4 medicine is very much dependent on what we call as systems biology, in which there is a holistic approach to understanding fundamental principles in biology and use emerging technologies in genomics, proteomics, single-cell analysis, microfluidics, and computational strategies to craft a comprehensive approach to medicine. So what is happening is we are being overtaken by technology and computational techniques, because the amount of data that is being generated is so massive that one or two or even a group of people cannot comprehend them. So when you see this mass of data coming from databases, from cells, from proteins, from proteomics, you need tools that can integrate this data so that it makes sense to the doctor in differentiating those that are diseased from those that are helping, or trying to find out those that will get a particular disease in future. So what is now happening is, because of these advances in computational techniques, the area that we call as bioinformatics, that is in fact assisting us to integrate these various technologies and interpret the results that we get from them. So that is very much part of what is called as systems biology. Now, the other thing that is very important here is that medicine now is embracing the other disciplines that are critical to understanding the whole disease process. So that's all part of what we call as the systems biology approach. Now, there are, as you will realize, some challenges. And one of them is that you need to invent the strategies and the technologies. So P4 medicine will very much depend on that. What are these emerging technologies? And then how do you use them? And then what impact would it have on society? Now, who knows what's happening in America? You know what is called as Obamacare, right? Obamacare is actually focusing on prediction and prevention medicine. And many physicians are actually frightened, because you might have situations where some of them will be without jobs. You know, there will be no patients, isn't it? I mean, you could have a situation where the number of patients coming for treatment will significantly decrease, because who will take over from them? It will be people who are training to prevent disease. So certain groups of certain specialists would no more be in business. I mean, even people in the lab are feeling threatened by what? They're feeling threatened by point of care that we know is already here and moving very rapidly. So we might have a situation 15 years from now, there might be very few labs around. You know, because people can test things at home. Instruments are easy to use, and the instruments can do a variety of tests. There's a machine out there, the newest Samsung. I do not know how many of you have seen it. It can do 25 biochemical tests just using a small, tiny drop of blood. 25 tests. Can you imagine that? Did you ever think 10 years ago that you will have a point of care instrument that can do 25 tests? Now that's where we're going. And then we will have to deal with the impact on society, and very importantly, ethical issues, social issues. We will need to have a regulatory environment as well as economic issues. And that's not what I'll be dealing with in this talk. It's beyond that. So this really summarizes what I have been saying for the last 10 minutes. So what we are having is increasingly we are seeing what we call as a cross-disciplinary culture, where teams of scientists from different professions are coming together. So there on the right hand you see who these people are. We're getting people from biology, chemistry, computer science, engineering, mathematics, medicine, and physics. All these people coming together to form a team. And this whole process is being driven by advances in technology and computation, okay, what we call as bioinformatics. And the information we are getting, the biological breakthroughs that are happening, they are actually happening due to the technological innovations. So technology is very, very important. And this becomes important for us here as a university, that we must embrace technology, because without doing that, we cannot move to the next level as other countries are doing. And it's a very vicious cycle. If you don't have those tools, you will not be able to analyze the data. So you must also have the computational tools. And that's why we have very near us here the Institute of Bioinformatics. So that was indeed very visionary of South Africa to put up that institute more than 15 years ago. I won't really go into this because I think we have I've spent already 15 minutes, but obviously P4 medicine will require new standards and new policies for handling biological and healthcare information about individuals, because it will be all about DNA information. So the kind of information you are going to get is going to be very different from the clinical information that doctors are traditionally used to. And it might even be different from the usual lab tests that we are used to. So you will now be getting genetic information. So you will really have to change the way you think. And complex data sets, as we know, will need to be handled securely and interpreted knowledgeably and thoroughly. So there could be mistakes. So you're having all this complex data that you are getting from information from fluids, from blood, from the DNA, and all this data will need to be put together to differentiate people from those who are diseased and from those who are not diseased, and also to look for what we call as trend analysis. And through that trend analysis, you will be able to predict where that person might be in 10 to 20 years' time. Now, is it really relevant to Africa? In fact, in my opinion, P4 medicine is very, very relevant. We need to be focusing on prevention, where we know that there's a high disease burden of both communicable diseases as well as the NCDs. For example, South Africa has 0.7% of the world's population, but 17% of the global burden of HIV/AIDS and 5% of TB. And indeed, Africa is said to be the fastest growing part of the world with diabetes. It's the fastest growing region. So diabetes is going to triple in Africa in the next 20 years. And this is because of the changes in lifestyle as well as urbanization. So therefore, what is personalized medicine? It's really a broad term of interventions that are targeted to individuals based on their risk in order to provide a more coherent and focused approach to healthcare. So that's a very broad definition. And it could include several others. But the most important thing to realize is that it could include preventive, diagnostic, and therapeutic interventions. So some of these things could lead to those interventions, with risk also being defined through genetics. So that's important, that genetics has also now become part of what we call as personalized medicine. So there are different types of personalized medicine, but it's important for us to realize that genetics very much underlies this whole concept, as well as clinical and family histories. So the more information you get from the patient with respect to genetics as well as family history, the more likely is that you will have a more accurate prediction of what you are studying. And the goals include, as I have said, greater effectiveness and efficiency of healthcare delivery, as well as improved outcomes. We all know what is driving it. It's technology, I've just mentioned, rising cost of healthcare, and many diseases, as we know, the common ones, hypertension and diabetes, in fact, have no cure. So, because they have no cure, you want to know what is your risk so that you can, at an early stage, maybe before 30 years, before the disease appears, you can start to take some measures to ensure that you don't get that disease in 30 years' time. So this pretty much summarizes what we have been talking about, that what is moving this whole field is informatics, enabling technologies, and all this information that we are getting from genomics, from informatics, they are all being integrated in this concept of personalized medicine. So you need to have each one of them for this area to go forward. And it has really been driven by key events. And some of us all know those key events. Between 1993 and 2013, we had the Human Genome Project. Subsequently, it was understanding the biology of genomes. That happened till 2010 and is still continuing. And currently what's happening is we are actually understanding the biology of disease. And as we understand the biology of disease, it then fits into the concept that I was referring to as systems biology. And in the next decade, what's going to happen is we are going to actually use this to understand the science of medicine. That's what we are that's where we are heading. And hopefully all these advances will improve the effectiveness of healthcare. In other words, whatever we do, it improves the healthcare. So you can also say what we are trying to do through all these emerging technologies is that you are trying to identify different types of genes. Genes that are important to prevent infection, genes that are important to support or prevent disease, genes that help us to detoxify drugs, genes that promote diseases. So that's where we are all heading. So you can actually divide them into 4 groups that affect our health. So this is a very important diagram because it actually tells you where we are. So this is where we currently are. You have typical intervention when a disease has already taken place. No, it's not working. Okay, and you can see that in fact you don't, the disease process starts well far behind, before the disease actually happens. So what is important is, through this P4 medicine, what you are trying to do is to evaluate the baseline risk over here. This is where you need to start evaluating the person. And you also need to find out what are the initiating events. Now, for you to do that, you need to have what we call as enabling tools. Now, what are these tools? What is actually going to help you? Now, these can be divided into what we call as stable genomics and dynamic genomics. Now, in stable genomics, what you essentially do is you are trying to identify the SNPs, you're doing haplotype mapping and gene sequencing. But these are very, they don't tell you much. They just tell you this thing is present. They don't tell you anything about the expression. So you move on to the next one, which we call as dynamic genomics, in which you like to see whether there is an expression of that particular gene with respect to its environment. So the two are therefore very important in predicting risk. So these tools are in the process of being developed, and in some cases they are already here with us. So that will tell us, so the initiating events then become very important for you to prevent that disease or even prevent its progression. So it's becoming critical that we focus in these two areas, because by focusing in these two areas, we are going to reduce the cost, which, as you see, rises. So the cost starts rising from here. Can you see that? From the earliest detection, it rises remarkably. So by actually getting your patients here, you would hopefully prevent them from going there. And that's the whole basic concept of genomics or personalized medicine, where in fact it can have a significant impact downstream with respect to cost reduction. And therefore what it does is this: it identifies people according to risk over a period of time. So you see low risk on the left hand side, high risk, and then what you can do is those with low risk, you can put up what we call as a personal lifestyle plan. Those with high risk, you can then identify them and put in some other measures that would try to lower their risk, such as lifestyle modification. Whilst on the right hand side, it would be, as we do now, it would be disease management. Now these are some common examples. Again, many of you know these examples, which are already happening, where the presence of a biomarker allows you to do what is called as personalized treatment. So for example here, HER2 new receptor, as you know, would allow you to select patients who will be given Herceptin. Similarly, for the other conditions as well. Once you have that particular polymorphism or gene, it allows you to selectively choose the patient who will most benefit from that therapy. And a common example is warfarin. We all know warfarin, isn't it? It's the most widely prescribed oral anticoagulant for preventing thrombolytic events, despite its narrow therapeutic range. And we all know you have problems with dosing, especially with respect to the patient's diet, age, and other medications. And in fact, warfarin is the second most common drug implicated in adverse drug reactions. And 1/3 of thrombosis patients metabolize their warfarin dose differently than that expected, due to a large part to variations in these two genes. Therefore, the FDA has actually recommended what we call as warfarin labeling, In other words, that before you put these people on warfarin, they must be tested for the presence or absence of these two genes, because they are going to influence the way your warfarin acts. And one of the other things that Marita was talking about is the integration of point of care with personalized medicine. In fact, this is happening more and more. Previously, point of care instruments were just used for very routine tests like glucose, cholesterol, but in fact, in the last 5 years, we have seen a dramatic increase to infectious conditions, but more even dramatic has been the ability of these small machines to do PCRs using the technique of microfluidics. So, for example, this was introduced. It's called the rapid gene, and this was introduced in 2010, and it was actually used in a study where they used point-of-care DNA testing successfully in patients who were undergoing cardiac catheterization. So this is already happening. This happened 2 years ago. And patients were successfully identified for the presence or absence of that gene, and cardiologists were then able to prescribe antiplatelet therapy according to the patient's genotype. And you know what was significant here? There were no lab people involved. This was actually carried out by nurses who received a 30-minute training session but had no prior lab training. And the test had a sensitivity of 100% and a specificity of 99.4. Can you see where we are going? So very soon we may also disappear. I'm talking people from the lab. So we need to be aware of what is happening and change accordingly. So what are the challenges facing, what's my time? Have I exceeded already? What are therefore the challenges facing Africa? Now what is critical here is that many of what we see does not apply to Africa. Why does it not apply to Africa? The reason is very, very simple. Africans are the most diverse people in the world. In fact, there's a study showing that if you took two Khoisan people next to each other, the amount of diversity they will see between themselves will be far more than what you see in two Caucasians. So there's a lot of diversity. And that's why it is important that we in Africa need to do this genetic work. In fact, if you look at some of the big projects that are going on, such as the Genome-Wide Association, there are very few African populations represented. In fact, we are actually going to do one of, well, I'm not sure, others are probably doing it, but we are going to do one for the mixed ancestry population, and that study is going to be done next year, where we are trying to look at risk for diabetes. But if you look in the literature, there are just one or two GWA studies carried out on Africans. And most of those that are there have used Nigerians. And a recent study has just shown that the Nigerian genome is very different from what you see in South Africa. So, and what is also remarkable is that in South Africa now, because there are very few studies from outside South Africa, but the few studies that have been done in South Africa, they have reported adverse drug reactions of 14%. So that's very, very high. That just tells you the amount of diversity we have versus the 6% I quoted in one of my earlier slides in developed countries with 10% higher fertility rates. So what does that mean for us? It means, therefore, that some of the HIV drugs we are giving are not effective, and some of them are causing very toxic reactions. Now, this has wide implications because it leads to drug resistance and it leads to poor drug compliance. So, therefore, we need to ascertain the genetic diversity and understand the genotype. So I see that there are lots of projects now coming up to look at this. We need to create biorepositories that will consist of unique and diverse populations. In fact, as we speak now, the first biorepository that will do this is being established in the Department of Pathology, and we've won quite a huge grant to do this. And this biorepository will collect samples from different African populations and store them for future research. But obviously, this kind of projects are fraught with ethical and cultural considerations, and these are being dealt with the Ministry of Department of Science and Technology, as well as with the Medical Council. So I will just briefly go to some of the emerging challenges. We need to have a proactive policy. We don't have a policy, but I'm glad to tell you that this is under discussion by the Ministry of Health in collaboration with the Department of Science and Technology. In fact, I was at a workshop 2 weeks ago on biorepositories, where the DGG spoke and told us that there is some legislation coming on it. We need to standardize our IT. There must be funding for translational work, very, very important. I was yesterday, I had a meeting from a company called PAC that's based in the US, and that was one of the critical questions they were asking. Does the work that you do ever get translated? And the sad answer is no. We have lots of research, but a lot of that research is never put into practice. And one of the projects we are doing is the reference range project, where for the first time we are going to produce evidence-based lab values for South Africans. And we are hoping that once that project is finished, we for the first time in South Africa will have biochemical values that are relevant to your racial group and age group. Currently, as you know, we use values from the States. And other issues, there are several of them. I think we're running short of time, but there are several of these issues. But one of the one I think I just want to point out is the regulatory environment. IP and regulatory environment, as well as who owns those samples once they have been deposited in a biorepository. And it's very important that when we are doing these studies, that we observe complete privacy and confidentiality, and therefore the degree of anonymization is critical. So I will skip that, and then we'll just conclude that though personalized medicine is here with us, there are significant challenges in Africa, and these challenges will require coordination across multiple stakeholders, and these would include government and universities, biopharmaceutical companies, genetic companies, diagnostic companies. So these would be the producers, and then they would need to interact with the consumers. These would be patients, there will be healthcare professionals, managed care, and also the medical aids. So who would actually pay for these services? What will be the regulatory framework? What would be the ethics? How do we deal with those kind of issues? Thank you so much for listening.